Hi, Mike Gibson, Colin here, and we're talking about the CorCMR study, very important study looking at CMR assessment in those patients who have non-obstructive coronary artery disease and angina. Tell us what you did and what you found, Colin.
Thanks, Mike. So we put in place a multi-center study that looked at the diagnostic and clinical value of stress perfusion CMR in patients who had undergone a clinically indicated coronary angiogram for angina or suspected angina, and yet had no obstructive disease. And at least 50% of the patients passing through our cath lab fall into this um, diagnostic group, and their management thereafter is quite uncertain. So, over 3 hospitals and an 18-month period, we screened and enrolled 273 patients. 250 attended for a perfusion CMR scan within 3 months of the angiogram. And we implemented some bias mitigation measures. So patients consented and were randomized just before the scan, but they weren't told what group they were in. The staff weren't told the randomized group. And as a reporting imaging clinician, I reported the blood flow from the stress perfusion scan, but I did not know the randomized group. So then we had standard SOPs linked to a diagnosis. And it turns out in 250 patients, the diagnosis would have changed in 53%. And treatments were changed accordingly in relation to mostly microvascular angina. And to my surprise, angina and health-related quality of life improved progressively at 6 and 12 months. Just to complete, these results were determined by patients who had no knowledge of their randomized group. The staff had no knowledge, and the data were analyzed by statisticians who were independent of the research team.
Did the patients who didn't know their results, were they treated with a placebo or were they not treated with anything? Or they just they didn't know if they had microvascular dysfunction, and they weren't
So
treated. Is that right?
yeah, yeah. So we were basically assigning a treatment plan in line with the standard care for a diagnosis. So, for example, if a patient had no obstructive disease, felt to be chest pain, then they had a perfusion CMR scan and it was normal, then any cardiac medication would be discontinued. If the perfusion CMR scan revealed a pattern consistent with coronary microvascular dysfunction, the medication would be changed in relation to calcium channel blockers and preventative therapies. They were also directed to rehabilitation. So there was no placebo. We were simply reassigning evidence-based guideline recommendations for endotypes.
Based on the scan, it was really a strategy trial, randomized strategy trial, testing a strategy of the imaging study that then led to a change in treatment, which in turn led to an improvement in angina.
Yes.
Yeah. Well, amazing. What, in addition to calcium channel blockers, did you give? Did you give statins or what were some of the other medicines?
Um, calcium channel blockers were the main medicines and also nitrates.
Nitrates.
Um, yeah, and also lifestyle and preventative, non-medicinal preventative measures. Look, we know these drugs were effective because blood pressure was lowered, and there were directional changes in relation to reductions in body weight and improvement in lipids. So we have mechanistic explanations for the improvements in symptoms and well-being.
That's great. Well, Colin, congratulations. This has been a bit of a mystery. We were in an evidence-free zone. You've added importantly to that evidence space. Very proud of you. Thank you for championing the microvasculature, the little vessels that don't get a lot of attention.
Yeah,
Patients, thank you for this. Thanks, Colin.
thank you very much, Mike.
And
All
thanks
the
for
best.
joining us here today from AHA 2025.